Good morning, afternoon, or evening. Thank you for joining us today. My name is Jordan Thornes, and I am the Vice President of Global Clinical Laboratory Operations. On behalf of LabPMM, we welcome you to this corporate workshop organized by the Association for Molecular Pathology. Today's webinar is titled, Integrating New AML Guidelines into Practice, How Multiparameter Flow Cytometry and NGS MRD Inform Treatment Decisions. Before we begin, just a few housekeeping notes. Please note that this session will be recorded and that these presentations will be made available after the webinar. If you have questions during the presentation, please submit them through the Q&A panel on the right side of the screen. Our first speaker is Dr. Sanam Loghavi, an associate professor in the Department of Hematopathology at the University of Texas MD Anderson Cancer Center and medical director of the ECOG Akron Leukemia Bank. She is board certified in anatomic and clinical pathology, hematopathology, and molecular genetic pathology, with expertise in hematologic malignancies, particularly myeloid neoplasms, AML, MDS, MRD assessment, and the integration of flow cytometry and molecular methods into leukemia diagnostics and monitoring. Dr. Loghavi earned her medical degree from Islamic Azad University in Tehran, completed her pathology residency at Cedars-Sinai Medical Center, and pursued fellowship training at MD Anderson Cancer Center. Our second speaker is Dr. Hong Drum, Laboratory Director of LabPMM, the Laboratory for Personalized Molecular Medicine. Dr. Drum brings extensive experience in pathology and hematology, with clinical experience, expertise spanning hematopathology, blood and tissue-based diagnostics, and laboratory testing. Dr. Drum earned her medical degree from Guangdong Medical College in China and has been board certified in anatomic and clinical pathology, as well as pathology, hematology, and hematopathology. Her background includes senior hematopathology experience in molecular and hematologic diagnostic laboratory settings, supporting the interpretation of complex hematologic malignancies and clinically relevant biomarker testing. At LabPMM, Dr. Drum's expertise aligns with the laboratory's focus on internationally standardized molecular and flow cytometry testing for biomarkers that support patient care in hematologic oncology. And with that, Dr. Loghavi, the floor is yours.
Thank you very much, Jordan. Thank you for that kind introduction. It's a pleasure to be with everyone here today. I think we have a lot of participants, and we're excited to get into this very exciting topic. All right, so today we'll be talking about really how do we incorporate AML MRD guidelines, both in terms of detection and in terms of their clinical implications into our routine practice as hematopathologists, diagnosticians, and both clinicians. These are my disclosures. All right, so what are the learning objectives for today? What do I want you to take away from today's talks? One is, we're going to summarize the current AML diagnostic guidelines. How do we classify AML? How do we risk stratify patients? And what are really the MRD time points that we're interested in and are recognized as being clinically important? And then we'll talk about the currently used assays in practice. We're going to describe how combining morphology, immunophenotype, cytogenetics, and molecular profiling helps us make an accurate diagnosis of AML that'll, help the patient across the disease course. We're going to compare the clinical and laboratory strengths and limitations of multiparameter flow cytometry and next generation sequencing MRD detection. We'll talk about the sensitivity of each method, in what settings do they apply in, the turnaround times, the disease biology that is relevant for each. And then we'll explain how combining both of these modalities is going to improve risk stratification for patients. We'll show you some examples of discordant and concordant MRD results by flow cytometry and next generation sequencing and what those mean in routine practice. And then we're going to discuss how MRD informs treatment decisions, both treatment intensification and transplant planning, and then post-remission maintenance therapies. Okay, so I think, most of the audience here is familiar that making an AML diagnosis doesn't really stop with morphology anymore. It's really a multi-layered process that takes into account, of course, the morphology of the bone marrow and the peripheral blood. A very important part of the diagnosis of AML is immunophenotyping, both for establishing a myeloid immunophenotype at baseline, but also for recording the phenotype of the aberrant myeloid blasts so that we can then follow them during remission and, during the course of therapy to identify measurable residual disease. cytogenetics is still one of the very important parts of AML prognostication and risk stratification, and also informs therapeutic selections. And then molecular methods, mostly, next generation sequencing for both DNA and RNA that pick up somatic mutations, and then fusion products that are, again, helpful for risk stratification, diagnosis, and potentially informing therapy selection. So with that, this is the current diagnostic tables for the ICC and the WHO for AML. You can see that the majority of AML, if I think about my clinical practice right now, the vast majority of AML is now genetically defined. So the vast majority have one of these drivers that genetically defines them. If there's none of these genetically defined markers, then we kind of refer back to AML by differentiation, which is, the phenotypic differentiation, or AML not otherwise specified is the terminology that ICC uses. But essentially, I would say 90-95% of AML is currently genetically defined, which is great because it helps us with follow-up, detection of MRD, and also accurate risk stratification. So when we think about these genetic subtypes of AML, we generally break AML into 3 risk categories. One is favorable, and of course, this is in comparison. There's no such thing as a favorable AML, right? But this is in comparison with the other ones. So favorable is really the ones that have NPM1 mutations with no other adverse mutations, core binding factor fusions, and then CBPA mutations in the BZIP domain of the gene, and that are in-frame mutations. And then intermediate, it depends on the risk stratification and the therapy that you look at, but if you consider ELN-2022 as the baseline, NPM1 mutated with FLT3 ITD is considered intermediate, and then anything that is not adverse or favorable is also intermediate. And then adverse is really mostly the complex monosomal TP53 mutated, KMT2A rearranged, and then myelodysplasia-related gene mutations or cytogenetic abnormalities. And this is the ELN-2022. We just talked about this, but one of the things that I want to highlight is that the ELN-22 risk stratification system is based on younger patients receiving high-intensity therapeutic regimens. So this was really not designed for patients that are receiving HMA and ven-based therapies, which is currently the standard of care for older patients above 60 or 65 years old, or those patients that are not fit enough to receive intensive therapy. So with that, the field recognized that we needed to update the risk stratification systems to be in line with our therapeutic regimens. And so, there's been a tremendous effort by multiple groups that have come up with what I think is now really 2 major risk stratification systems for patients being treated with less intensive therapies. One is, again, by the ELN group, which is, either called the ELN-2024 or the 4-risk gene classifier. And here you can see that the adverse group has really shrunken into only the TP53 mutated patients. And then favorable cases are NPM1 without RAS pathway, TP53 or FLT3, IDH2, again, without these mutations, IDH1 and DDX41. And this is mostly because these genotypes are highly sensitive to ven-based therapies. And then anything that is not adverse or favorable is considered to be intermediate. Now, the one thing I want to point out to you here is that this the 4-gene classifier does not take into account the karyotype, right? So this is not based on genetics. So then there was an effort really mostly led by Curtis Lakowitz, but this is a multi-institutional effort, and they looked at a large number of AML patients treated with HMA and ven-based therapies. They integrated 17 clinical and genomic variables, including cytogenetics, and this is a risk stratification system that takes into account, again, clinical parameters, gene mutations, and then cytogenetics. And there's a really nice online calculator. It's prismaml.com, I believe. And if you just put in the parameters of the patient at baseline, you get a really nice risk score that really outperforms the 4-gene classifier, and of course outperforms ELN-2022 for patients that are treated with HMA ven-based therapies. Okay, so what about the role of MRD? So we know that our risk stratification systems are not static, right? So it depends really on how the patients respond to therapy. And one of the best ways to sort of modify, if you will, the baseline risk stratification is to look at measurable residual disease, which is a measure of whether or not the disease is responding to the therapy we're giving the patient or not. So there's, I don't need to tell you that measurable residual disease is prognostic. I think the best or most comprehensive study is a study that was done by Nick Short that looked at essentially thousands of patients across different studies, looking at the prognostic impact of MRD. And regardless of what method you look for MRD, MRD is prognostic. It's just telling you that there's residual disease there. This is very, I think, intuitive, right? If you have residual disease, of course, the patients are going to do worse. But, there are a lot of different things to take into account when we think about MRD. One is, how are we measuring MRD? The other is, how are we reacting to MRD? When are we measuring MRD? And I think these are the questions that have kind of remained in the field, not necessarily that MRD is reliable. We know very well now that, at any time during therapy, if the patient has molecular evidence of relapse or rising MRD, those patients are destined to relapse if you don't intervene, right? And so with that, this was a really nice effort by the UK group where they looked at two different studies, so the AML 17 and AML 19, in which there was intervention, so there was monitoring for MRD, right? So the top curve shows you just across the entire group, the overall survival, according to randomly assigned groups, considering patients in both trials. And here, molecular MRD is not taken into account. So we're just looking at the survival. Now, if you come down here and look at patients that had FLT3 ITD and NPM1, so the bottom graph is restricted to FLT3 and NPM1, and for patients that had MRD monitoring, you can see that they had better survival because there was intervention at the time of MRD relapse, right? So this is clearly evidence that we should be acting on MRD. And then the other is that, there's very nice data from Jad Othman and his group where they looked at, if you remember, I told you that patients with NPM1 and FLT3 mutated disease are considered intermediate risk and potentially considered for hematopoietic stem cell transplant. In this nice study, they really showed that if the patient cleared their NPM1 mutation prior to transplant, really there was no survival benefit to receiving a transplant. So there is a move in the field. Some people may not still be acting on this, but this is certainly a consideration in which we are thinking maybe patients with NPM1 mutated, FLT3 mutated AML that clear their NPM1 mutation with highly sensitive NGS-based assays can be spared from receiving a hematopoietic stem cell transplant, which is not a trivial, it's associated with its own highly significant morbidity and mortality. All right. So the other issue in question is maintenance therapy, right? How does MRD inform our maintenance therapy? And I think there's several trials that have tried to address this question. One of the largest phase 3 trials is the Quantum Wild trial, the Quantum 1 trial, where they looked at FLT3 mutated patients and looked at the role of the addition of a FLT3 inhibitor in addition to chemotherapy, and then looked at the significance of MRD and how this informs maintenance therapy. So if you look at the overall conclusion of the assay, it was that quizartinib provides survival benefit over placebo, regardless of the MRD status, right? So this is the main conclusion of the assay. But I think here the devil is in the details. And if you if you look at the way the study was done, they used a highly sensitive NGS MRD test to look for FLT3 ITD. They used two cutoffs for this study. One was 10 to the minus 4, which was the LOD or the LOQ of the assay. And then the other was just MRD 0, undetectable MRD, right? And if you look at these two different cutoffs, and if you look at the context in which these were applied, you can see, so the top 4 graphs show you the quizartinib arm. And if you look at MRD by 10 to the minus 4 cutoff versus 0 cutoff, and we look at patients who were MRD positive versus MRD negative and received quizartinib, the difference is not that big, right? In fact, in here, it's not significant at all, right? If you look at 0, if you look at MRD 0, and this is now 30 days prior to receiving, 30 days prior to consolidation, then you can see that having MRD is actually the patients that are benefiting from quizartinib are the patients that have MRD, right? So there's a big significance here. And then if you look at the placebo arm, of course, the patients that did not receive quizartinib, you can see that MRD in every setting is very prognostic, right? So here, really, you can kind of draw a conclusion that maybe the benefit of and this is all in patients that had not received a transplant. So maybe the benefit of maintenance with quizartinib is really in patients that do have evidence of MRD. All right. What about impact of FLT3 on the likelihood of relapse? And, this is, again, a really nice study that looks at the various methods by which we look at MRD. So capillary electrophoresis, which is, the routine assay that is used in most of the laboratories, typically has a sensitivity of around 1%. And then you have NGS MRD here in the middle, on the left-hand side, the blue dots, and then patients that are completely negative below the level of sensitivity of the LOD. And this is, very intuitive. So the higher levels of MRD you have, the more detectable MRD you have with a less sensitive assay, the worse the outcomes are going to be and the higher the likelihood of relapse. And then this is particularly important in the pre-transplant setting. And here we're looking at specifically NPM1 and FLT3 mutated patients. So patients that clear both mutations pre-transplant have outcomes that are highly superior to patients that don't clear either of the mutations. And then if you have one residual mutation, you're kind of there in between, right? And I think all of this makes a lot of sense and is very intuitive. Okay. What about in, using another FLT3 inhibitor? So here, this is another trial that looked at gilteritinib. If you look at just MRD status in the entire cohort, not stratified by treatment arm, of course, MRD positivity is associated with increased risk of relapse, and then decreased risk of probability of survival. And then if you come and look at patients that received gilteritinib versus placebo, you can see that the advantage of receiving gilteritinib is really in the MRD positive arm, versus if you look at the MRD negative arm here on the right lower bottom panel, the patients that received gilteritinib and placebo did similar, right? So this means that the benefit of receiving gilteritinib were in the patients that were MRD positive. All right, so, we talked about the prognostic and the risk stratification importance of MRD, but how do we measure MRD and when do we measure MRD? So, every patient with AML gets a baseline diagnostic workup that we talked about that includes immunophenotyping, where we look for leukemia-associated immunophenotypes, and then, of course, molecular targets. Here we say molecular targets because this is in the context of an MRD talk, but we're really talking about molecular drivers of disease, right? And then after 2 cycles of intensive chemotherapy, we usually repeat the assays. We look for measurable residual disease by flow cytometry, and depending on the molecular driver of disease that they had, we look for a molecular target. And then typically before allogeneic hematopoietic stem cell transplant for patients that are moving on to allotransplant, and then at the end of treatment, and then regularly during defined intervals after a transplant or after consolidation therapy. So what are the different methods? These are based on the ELN-DAVID 2025 guidelines. So NPM1, core binding factor, PML-RARA, and KMT2A rearrangements are recommended to be followed up by either qPCR or digital PCR. But again, we, at least at our center, we use an NGS-based assay for NPM1, and I know that InVivoScribe does the same. Ultra high sensitive NGS, again, this is for NPM1, FLT3, ITD, and then there's definitely an effort from the ELN-DAVID to design more broad NGS whole genome sequencing assays that look for additional genes. But right now we have NPM1 and FLT3, and then of course multiparameter flow cytometry that looks for leukemia-associated immunophenotypes or different or deviation from normal phenotypes that applies essentially to all patients, right? Because 99.9% of AML is associated with an aberrant immunophenotype. So I put this table here really as a reference, and you can go back to this table. It's a really nice paper in Blood published by, again, the ELN-DAVID committee. But this really tells you that the guidelines are stratified, first of all, by the genotype of the baseline genotype, right? And then there's a recommendation of what assay to use for each genotype. There's a recommendation of what analyte to use, so whether to use peripheral blood or bone marrow. And I can tell you as a general rule, the more ominous a molecular marker is, like FLT3 or KMT2A, the deeper you want to look. So you want to be looking at the bone marrow, which is the source. And as a general rule, typically bone marrow has a log, 1 log higher MRD if you compare it to peripheral blood, right? So bone marrow is definitely a more sensitive sample, but of course peripheral blood is easier to get, and in some genotypes it's sufficient, such as NPM1. And then, the timing is recommended. So after 2 cycles of therapy or before hematopoietic stem cell transplant, end of therapy, and then for follow-up. So this is a really nice comprehensive table. And then there's also a calculator. So the ELN-DAVID also has a calculator that tells you exactly what you need to do based on the baseline genotype. Okay, so what are some of the strengths of multiparameter flow cytometry compared to other methods? I'm a big fan of flow cytometry, and I know that the field really wants to say that molecular is more novel and better, but in reality, flow cytometry continues to be very helpful. It may not be as objective, but it's definitely very helpful. One of the best or most important strengths of flow is that it applies to nearly all patients because there's no specific target that you're going after. You're just looking for a deviation from normal or an aberrant immunophenotype. It has very rapid turnaround times. In our lab, we can do this in a day. So it's very rapid. It's relatively cost effective compared to the other testing modalities that we have. Again, we can look for leukemia-associated immunophenotypes and deviation or different from normal phenotypes. And then it really is a single-cell method of quantification of residual blasts. But there are limitations. I think, one of the most important is that it requires standardization and expertise. It's still not easy to do. I've been doing this, I think, for 10 years, and there are still challenging cases. So it's definitely not very straightforward. But for the most part, I think it's very, very reliable. There's phenotypic shift. AML is a heterogeneous disease. You can either have disease heterogeneity at baseline and some clones persist and others go away. That can give you trouble when you're trying to follow a specific immunophenotype, or sometimes the phenotype just changes after differentiation-inducing therapies, such as menin inhibitors, and I'll show you an example of that. The sensitivity is around 10 to the minus 4 at best, I would say, and this is if you have a really good sample. And then, of course, there's no direct readout of a driver genotype, right? And then what about molecular? I think molecular tends to be a lot more popular, especially with our clinical colleagues, because it's a black and white, answer. You're tracking, defining molecular lesions like NPM1, FLT3, KMT2A. The assays that we currently have, and this is really somewhat new in the last, I would say, maybe 2-3 years, this has caught on really well. They're highly sensitive. So we can pick up MRD at around like 10 to the minus 5, 10 to the minus 6 sensitivity. So this is like 1 in a million cells or 1 in 100,000 cells. And then it detects de novo or emerging variants at the genotype level. And again, as I said, it's objective, quantitative, and reproducible. What are some of the limitations? The limitations is that you're looking for a specific target. So if the leukemia evolves, you're going to miss that target. The longer turnaround time compared to flow is an issue. There's clonal hematopoiesis. Not all molecular markers of disease have equal weight in their determining risk of relapse, right? We know about the DTA or the DNMT3A, TET2, and ASXL1 not being prognostic at all. And then it requires a trackable target at baseline. So this is really just a side-by-side comparison of what I just told you. Again, I think if I had to really pinpoint the limitations of both assays, for flow, it's really that it requires high levels of expertise. And then for NGS, I think it's confounder mutations and then clonal evolution. All right, so this is a nice study from MD Anderson where by our group, actually, where we looked at post-transplant relapse. And really, this is to show the strength of flow cytometry. So in 96% of the patients, flow was able to pick up low levels of MRD before frank relapse after transplant. And in fact, flow was the best method of looking for MRD. And then there was concordant MRD positivity in the majority of the cases that identified the highest risk patients for relapse. But again, for the most part, we were able to pick up the early relapses by flow as opposed to other modalities that we use in parallel at our laboratory. The other thing I want to highlight for you is that if you're only looking, let's say you have an AML that's FLT3 mutated, you're doing serial FLT3 testing for MRD detection for follow-up. Unfortunately, because we use targeted therapies such as FLT3 inhibitors, AML is pretty smart and it clonally evolves. So about 50% of these patients tend to relapse with FLT3 wild-type disease and acquire additional mutations such as RAS pathway mutations. So again, if you're not using flow and if you're only doing FLT3 MRD, you're likely going to miss that very early relapse in this patient. Similarly, NPM1, we used to think of NPM1 as being a very stable mutation with cytarabine-based regimens. But this is another study by our group out in AJH last year, where we looked at NPM1 mutated patients in the setting of ven-based therapies, and about 45% of patients actually relapse with NPM1 wild-type disease that we think may be completely new AMLs, right? They have different phenotypes, but again, we were able to pick these up by flow before we were able to pick them up molecularly. All right. So what do we do in practice? In practice, really, we combine both methods. We combine flow cytometry and NGS. We're most confident where both are positive and you have evidence of, disease. This is true residual disease. If both are negative, this is very reassuring. It's, indicative of deep response. And then if you have NGS positive, flow negative, things you should be thinking about are potential phenotypic shift, potential clonal hematopoiesis that is not really leukemia. And then if you're flow positive, NGS negative, you really want to think about clonal evolution like the examples that I showed. All right, so I'm just to briefly, touch upon this study that we have in menin inhibitor treated patients. I just want to highlight for you that, because most of these patients were KMT2A rearranged patients, and at the time we were not doing KMT2A MRD at our center, this was mostly done by flow. We looked at, response and relapse samples in patients that were treated with menin inhibitors. And there was a shocking degree of phenotypic shift because, obviously menin inhibitors are differentiating agents. So they induce differentiation in the blasts. And, we noticed that about 52% of the patients showed immunophenotypic change post-remission. In patients that remained MRD positive, 67% had a different phenotype compared to the original phenotype. So if you're only looking for leukemia-associated phenotypes and not applying the deviation or difference from normal, you may, risk missing these patients. And then 64% of patients actually relapse with a completely different phenotype. And, this is just a table that shows that this is here for your reference. If you're interested, you can look at this table. But it's a graph that shows the degree of phenotypic shift in the baseline on the left-hand side compared to the phenotypic post-menin inhibition with, in patients that were MRD positive. And you can see that, in some of the patients, at least, the change is not subtle. Some patients went from a completely myeloid phenotype to a monocytic phenotype. Some patients went back from a monocytic to a myeloid phenotype. So there was a lot of variation that it's important to be aware of. And then in terms of treatment response, of course, patients that achieved MRD negativity did a lot better, and had better outcomes, which again is not surprising. Here, I want to show you one case of a patient that had received a differentiating inducing agent. So this patient was treated with an IDH inhibitor. This is actually the remission marrow. It shows you that there's, morphologically nice differentiation. The myeloid cells are maturing. There's no increase in blasts. Here you have a mixture of erythroid cells. You have maturing myeloid cells. There's, of course, dysplasia, but there's no increase in blasts. This patient at baseline had an APL-like immunophenotype, this gray population here, that was positive for 117, negative for 34, positive for 123, and negative for HLA-DR. If you look at the MRD sample by flow cytometry, where these blasts were, here now is completely empty. There's no flow cytometric evidence of disease, even though this patient had an adequate sample. But then if you look at the NPM1 NGS MRD, and by the way, this is a day 21 bone marrow. So if you look at the NPM1 NGS MRD, there's high levels of residual NPM1. This is equivalent to so the VRF is equivalent to about a 37% VAF. But, if you looked at this result in isolation, you would say that this patient actually has residual disease. But if you look at the NPM1 IHC, which, we're fortunate to have this IHC marker to kind of look at and corroborate these results, you can see that the cytoplasmic staining is in the maturing myeloid cells. So this is really leukemia differentiating. And if you give this patient enough time, they're going to clear their disease. So how does MRD inform management across disease course? Again, I think, you want to monitor the patients to detect early relapse. And these are, again, the AML 17 and 19 trials that looked at, the monitoring patients for molecular relapse. You can see that on the left-hand side are the patients that were being monitored for molecular versus on the right-hand side, patients that were not. And you can catch a lot of these, a large subset of these patients in molecular relapse. And if you intervene early enough before the patients are very sick, at least the hypothesis is that they're going to have better outcomes. Of course, peri-transplant MRD detection informs whether or not the patient is going to get post-transplant maintenance, and of course, for longer-term follow-up. In terms of what LabPMM currently offers for AML MRD, so they have a really nice diagnostic FLT3 assay that is the capillary electrophoresis base for baseline. They have the standardized flow cytometry that is a 12-color flow cytometry panel that again looks for leukemia-associated immunophenotypes and deviation from normal with a sensitivity of 10 to the -4. And then they offer FLT3-ITD, NPM1, and KMT2A MRD testing. The first two by NGS and then KMT2A by ddPCR, and these are highly sensitive assays and currently available clinically. So again, just to summarize, I think, we talked about risk stratification, we talked about the MRD guidelines of when to do MRD, what specimen to use, how to combine using NGS and flow cytometry for better, improved risk stratification and information. And then, of course, we talked about discordant results and how you can potentially reconcile those results in the setting of in an actual clinical setting. And with that, I will be happy to hand over the presentation to Dr. Drum, and then we'll take questions at the end. Thank you very much for your question, for your attention.
Good afternoon. Thanks for the opportunity for sharing a few cases from our practice today. The cases I'm going to show mainly is our AML flow cytometry cases and FLT3 mutation and NPM1 mutation by NGS. Let's look at the first case. This is an 18-year-old young man with a history of AML. In December 2024, outside flow cytometry performed on a bone marrow aspirate, so it's about 42% aberrant myeloblasts that are negative for CD34 and have relatively bright CD117, have some dim CD123, and have a little bit of CD7. So the specimen received was a bone marrow aspirate. At flow cytometry, about 0.81% aberrant myeloblasts were detected. You can see here when we get on the CD117 positive and CD45 dim population, we can see one tight cluster here that is negative for CD34 and have a relatively strong CD117. And these cells have very dim parts of CD123 and CD7 have on a small subset. I'm not showing here, and you can see the HLA-DR is a little bit decreased. Obviously, this is a population of aberrant myeloblasts that is negative for CD34 immunophenotypically, very similar to the immunophenotype described at initial diagnosis. And at the same time, FLT3-ITD MRD NGS assay was also performed. You can see here we have 3 mutants, ITD lanes here. All of them are very low level. One is 33 base pair at 3.11 times 10 to minus 5. And the second one is at the level of 10 times minus 6. And the third one, again, is very low level at 10 times minus 5. And this the bone marrow received in January 2025, end of January. And early March 2025, we received bone marrow aspirate from same patient. And by flow cytometry, you can see a population of aberrant myeloblasts was identified, and the percentage of the population is relatively low. It's 0.03%, and the immunophenotype is almost identical to the one identified previously. You can see again this CD34 negative, CD117 positive aberrant population is here, and with similar expression of CD123 and HLA-DR, same as CD7. And at this point, the FRIP3 IgD MRD NG assay was performed, and you can see the same IgD was identified at similar level, 10 times minus 5. And you can see the 10 times minus 6 one drop at this time, and it was no longer detectable. In early April 2025, we received bone marrow and blood at the same time. The flow was done on the bone marrow aspirate. At this time, we don't see a tight cluster in this position anymore. What we see is a few sporadic dots in this area, you can see. And these cells, most of them do not have CD123. So this is interpreted as negative for flow cytometry. And at the same time, FRIP3 IgD MRD NGS assay also is negative, no longer detectable. And this about 1 month later, we received bone marrow aspirate, and again, this time is negative, and by molecular FRIP3 IgD also is negative. And we have continued sequential follow-up on this bone marrow. You can see July 2025, September, and November, and up to May 2026 for bone marrows, they're all negative. And the FRIP3 IgD by NGS also is negative. So we're showing excellent concordance between these two tests. And this is the summary on this patient's sequential MRD monitoring. You can see, just like we first saw, the blood was about 0.81% by flow cytometry, and FRIP3 IgD NGS was positive at the level of 10 times minus 5 to 10 times minus 6. And this we were able to track down the blast, decreased to eventually negative and maintain negative after that. This is some additional information. It's kind of interesting I'm showing here. The first bone marrow, when we received, actually 1 day before the bone marrow aspirate was received, we actually got a peripheral blood sample. They both have flow cytometry data. And you can see the percentage of the blast in the blood sample is 0.03%, and versus next day the percentage of the blast in the bone marrow was 0.81%. And you can see almost the same day, the percentage of the aberrant blast is more than 10-fold in the bone marrow compared to the blood. Now let's move to second case. This is a 60-year-old gentleman, has a history of AML, and this is the bone marrow collected in February 2026. You can see here, this is the blast we identified by flow cytometry. You can see this blast is showing good maturation. This is CD34 versus CD38. CD34 versus CD117, good maturation pattern. And CD13 versus CD34, again, very nicely maturing. And this is CD34 versus CD33. And this is the CD34-117. We can see the blast here, good maturation pattern, and have a little bit mast cells here, which is perfectly normal. So this is a normal bone marrow by our flow cytometry. So this is the sequential MRD monitoring data. The flow cytometry I was showing was this one on February 2024. At this time, flow cytometry was negative, but the first three ITD MRD assays and NPM1 MRD assays both were positive. You can see at relatively low level, 10 times -5. And before that, there were several bone marrows, and you can see first time ITD was positive, NPM1 was negative. And a few months later, ITD positive and NPM1 both positive. And then in March 2025, the NPM1 level was very low, 10 - 6, and this time ITD was not detectable. So we can see again the good concordance between these two tests. And this time you can see the flow cytometry was negative, but by molecular, these two were positive. You can see the sensitivity by NGS for this group of AML is sensitive than flow cytometry. And now let's look at the last case. This is a 72-year-old gentleman with history of AML. This is our flow cytometry. You can see this large population of aberrant blasts. They are showing relatively bright CD33 and HLA-DR, CD11B, CD64 and CD4, all these monocytic associated markers. And these cells at the same time have decreased CD45 and lost CD13 and CD14 with uniform aberrant CD56. So this is a population of immature monocytic blasts or myeloblasts with monocytic differentiation. In addition to the large aberrant blast population, we can see there's a small population of CD34 positive myeloblasts that is showing relatively high CD34 and retain the CD13 and have some CD117. They don't have monocytic associated markers. They are negative for CD64, CD11B, and negative for CD56 or very little CD56. So basically, this is a second aberrant blast population in the same case. The value of identifying this small CD34 positive population by flow cytometry is very good to identify this population after treatment, because after therapy, so often the myeloblasts with monocytic differentiation can be difficult to identify. As we know, after therapy, the monocytes can show variable CD56 and very variable other myeloid or monocytic associated markers. But this additional CD34 positive myeloblast often keep the original immunophenotype, so it's very helpful for subsequent flow cytometry study. And we don't have molecular testing on this case. So basically, this case is from a clinical trial. We can see at the screening point, we have large population of myeloblasts with monocytic differentiation, and at the same time, we have a second aberrant myeloblast population, which is relatively small. And after that, we received 3 bone marrow samples. One is in at the end of first cycle and the second cycle, and after stem cell transplant. They're all negative by flow cytometry. So to summarize the benefit of our combined flow cytometry and NGS for FLT3, ITD, and NPM1 approach. You can see, as we saw, our flow cytometry assay can detect pretty much all the immunophenotype of AML, including CD34 positive blast, CD34 negative blast, which could be sometimes a little bit challenging, and monocytic myeloblasts, and have very good sensitivity. It's 0.01%, as we saw in one of our cases. Before turning to negative, it was 0.03%. And we can show the aberrancy. Either there is immunophenotypic shift or not. This is for all the different type of AML. For AML with FLT3 mutation or NPM1 mutation or both, we have very good NGS-based MRD assays, and the sensitivity goes to 0.05%. And with this assay, we can track the unique sequence and length of multiple FLT3 ITDs and NPM1 mutations to support therapeutic decision-making, such as transplant or other treatment decisions. And when we compare these two assays, the NGS have a higher sensitivity. And we often use both together because by flow cytometry, we can see the percentage of the blast and the immunophenotype. They both have good concordance. And this helps us to detect relapse earlier and inform therapy. And we can also, at the same time, we help the industry to develop new medication for our AML patients. Thank you. And any questions?
All right. Well, thank you, Dr. Loghavi and Dr. Drum, for your outstanding presentations today and for leading us through the latest AML guidelines and how flow and NGS MRD can be used together to inform treatment decisions. We'll now move to Q&A. If you haven't already, please submit your questions using the panel on the right side of your screen. So the first question we have is, this is for Dr. Loghavi. You shared some data of menin inhibitor therapy and showed over half of the patients had phenotypic shift after the treatment. Does it suggest menin therapy is not effective, or what are your thoughts on those patients?
Not at all.
Are they not for NGS assays?
Yeah, so let me give you a little bit more context about this. I think, because of the time, I didn't really go into a lot of details. So the data that I presented on the menin inhibitors, this was in a single agent therapy, very early menin inhibitor trial. These patients were all treated with single agent revumenib, and they were multiply relapse refractory patients, right? So heavily pretreated. Of course, the disease is going to be much harder to eradicate in those patients. It doesn't at all speak to the fact that menin inhibitors are or are not effective. In fact, I think for the population that was treated, the response rate was pretty impressive. However, it does tell you that, in general, with differentiating agents, and this is not limited to menin inhibitors, it includes IDH inhibitors, it includes FLT3 inhibitors, any agent that can really cause differentiation, especially in the setting of monotherapy, where you're not combining it with an intensive chemotherapy that's going to wipe out the blast and the marrow, it can actually lead to differentiation of the blast. This is very similar to the phenomenon that we see in APL, acute promyelocytic leukemia, where you treat the patients with ATRA, the blasts go away, but if you do FISH early on in the setting of therapy, you're going to see high-level residual fusion. So I think one thing to be aware of is the phenotypic shift. Not in all of them. It doesn't necessarily mean that the disease is not responding, but it, of course, makes our job a little bit harder, because if you're looking for, a leukemia-associated immunophenotype that is exactly identical to the original disease, you may miss it. Conversely, there were cases, we actually did on a few of these cases, we did KMT2A MRD retrospectively, and the degree of immunophenotypic aberrancy sometimes is far beyond what you would expect for normal differentiating monocytes or myeloid cells. So I think the point of this study was really that you have to use these assays in combination, and they're complementary. And, especially in the setting of differentiation-inducing agents, flow cytometry alone may be very difficult to interpret if you're looking at it in isolation.
All right, thank you. So the next question from the Q&A, does Dr. Loghavi or Dr. Drum, do you have any thoughts about sorting phenotypic cells and then performing NGS testing? I'm presuming to boost the sensitivity of the assays.
Yeah, I'm happy to answer. I don't know if Dr. Drum wants to answer first. Or
maybe Dr. Loghavi, if you could.
Yeah, sure. So, if you're sorting cells, I assume you mean like sorting CD34 positive cells or, CD117 positive cells, depending on the blast phenotype. Of course, you're going to increase your sensitivity, right? You're essentially enriching for potentially blast populations. But one thing I'll remind you of is that, first of all of our guidelines are based on non-sorted cells, right? So the sensitivities that have been established, their clinical relevance that has been established is based on non-sorted cells. So I think you're going to increase your sensitivity. Whether or not that is going to actually translate into, clinically actionable results, I think you're going to have to do prospective studies to show exactly what, that level of sensitivity means. I can tell you that, from our experience with, and not just ours, I think, very reputable groups and published and highly cited papers, it seems like there's a difference in the genotypes. So for instance, there's no level of FLT3 ITD that is safe. Even if you have one residual, sequence that is mutant, that is meaningful, right, in the bone marrow. Whereas, very low level NPM1 in the bone marrow may not be as meaningful. And that's why actually the ELN recommends that you test peripheral blood and not bone marrow. And then you look after 2 cycles and not after 1 cycle. So I think there's a difference. But again, I don't know what, I'm sure you're going to increase the sensitivity. I don't know what that would mean.
Oh, great. And I think we have time for at least one more question. So how should we approach fluctuating MRD assessed by MFC and AML? For example, negative after 2 cycles, and then positive after 3rd cycle, and then maybe going back to negative again. How would you address?
What was the first part of the question? How do we work?
So, fluctuating MRD results in flow cytometry.
So essentially, when to do it?
No, how would you address it when a patient maybe goes from positive to negative, and then positive, or back and forth, right? And you're not getting the same result at each time point.
Yeah, I mean, I think this is highly context dependent, right? For instance, I think, of course, going from positive to negative is always good, right? That's never bad. But you have to take into account, several things. You want to make sure that the specimen you're looking at is actually an adequate specimen, right? An insufficient negative sample is not the same as having an adequate sample. I think oftentimes, especially for flow cytometry, one of the challenges that we have, particularly with patients that are, being treated with Ven-based therapies and they're, multiply treated, you'll get empty marrows. There is no CD34 positive compartment to look at and characterize. And so that's not as informative. But of course, I think going from a negative to a positive result is highly concerning, especially if you're, let's say, after allotransplant. That's highly concerning. It really depends on the time. It depends on the assay you're looking at. It depends on the therapy the patient is getting. But of course, rising MRD is invariably associated with frank relapse if you don't intervene.
Okay. So thank you very much. We are out of time, but we do have your questions in the Q&A, and we may address those directly to you later. So thank you for the questions. We will try to answer all of your questions, but we are close. So as we close, we just invite you to bring greater confidence, speed, and consistency to AML MRD assessment with LabPMM, our globally standardized lab. Network offers 12-color flow cytometry with machine learning assisted interpretation and same-day turnaround. Ultrasensitive NGS-based FLT3, ITD, and NPM1 MRD testing, and a newly launched digital PCR KMD2A MRD service for major AML-associated rearrangements. Now, together, these complementary methods provide sensitive, standardized insights that can help detect residual disease, monitor response over time, and inform AML therapy and transplant strategies worldwide. To learn more, please scan the QR code to get in touch with the sales rep. We've now reached the end of our webinar, so on behalf of AMP and LabPMM, we want to thank everyone for your attendance at today's webinar.